request the chairpersons to introduce the speaker. What do you think?
Dr. Alok N. Ghanate. He is professor and HOD at MRMC, Department of Psychiatry. He completed his MBBS from MRMC, did his MD at DY Patil, Navi, Mumbai. He is a consultant psychiatrist in his own nursing home. He is a PG teacher, guide and examiner since the past 8 years. He is the honorary member of Indian Medical Association, Indian Psychiatric Society, Karnataka chapter, and also a member of IPS South Zone, KKPG, and Deccan Psychiatric Association. He has published around 15 papers in which are peer-reviewed national and international journals. He has published around 15 papers in which are peer-reviewed national and international journals. Has conducted symposiums on internet addiction and homophobia at ANSYS. Participated in more than 40 talks on various psychiatric topics and issues. His areas of interest are psychopharmacology, psychotherapy, community psychiatry, general psychiatry, de-addiction psychiatry, and organic psychiatry. This is just an introduction of.
I would like to add 2 more points. When we started KKPG, I was the president and he was the secretary, and we conducted so many state programs here, including Differential and CPM. So, and he looks like Prince of the Basaveshwaran Hospital, and he is so wise. He has arranged tea before his session, so that nobody will speak. Thank you.
Over to you, Alok.
Yeah. Thanks for the kind words, sir. The tea was just a coincidence, not before my session. Okay. So to start with, after giving or listening a talk of sir, it's a real tough time to match up to his expectations. So we started thinking about doing a CME on insomnia first. That's what was my thought process. Now the whole topic converted into sleep disorder CME and insomnia being a part of this CME per se. Justifying this into 1 hour or 40 minutes talk is a bit difficult, but I try to cover up whatever time we have today. Today I will be discussing in terms of introduction, magnitude of the problem, what are the criteria, how we need to assess clinically insomnia, are there any medications which contribute to insomnia, what is the relation of our psychiatric disorders and insomnia, how we need to assess them by using some tools, how we need to formulate if a patient approaches us with insomnia, what are pharmacological and non-pharmacological treatment options available for us. Let us start with the case vignette. We all know that everyone in this class and outside, we do have suffered from one or the other form of insomnia kind of a thing in our lifetime. In a night, we may not be able to sleep before exams or before any stressful life situations or whatever it is. Here, to start with the case vignette, a 29-year-old woman presenting with persistent sleep difficulty since 2 years. She says she goes to bed at around 10 p.m. most of the time. She doesn't have much difficulty in falling asleep, but has multiple awakening in the night, which starts at around 2 a.m. morning. Most of the time, she tries to stay in the bed, hoping that she will get sleep. She tries to watch TV before she gets asleep. At times, she does take some snacks, like eating something or something like that, 1 or 2 times in the late night itself. When her alarm clock rings at around 6 a.m., she feels sleepy. Daytime effects, as she is not getting the sleep in the night, are decreased concentration and fatigue, which is throughout the day. Occasionally during the weekend, she has been seen having some naps. So this is a classical case of insomnia, which few of the patients who are coming to us complain of. Let us understand this lady in better by understanding insomnia in detail. Criterias, as Dr. Chandrasekhar has covered it, I don't want to spend much time on it. Here, there are three important things, either of one if they are present, like difficulty in initiating, maintaining, or early morning awakening. Either of three, if one is present, you call it as insomnia. It has to cause some impairment in functioning and distress. They have to be present 3 nights per day and for more than 3 months duration. Here, C criteria is very important. This lady or the person who is complaining of insomnia should get an adequate opportunity to sleep. Most of the time, few people don't get opportunity to sleep because of shift work or some kind of a noise in the room or surroundings that do help us not getting sleep. The current literature, most commonly, earlier we used to diagnose it at primary insomnia and secondary insomnia. That is completely taken off now. Now the insomnic disorder is completely separate entity. If you feel it is something comorbid to this insomnic disorder, we specify it as a psychiatric disorder or with a medical condition or with a sleep disorder comorbidity per se. So this new classificatory change has come up in insomnia per se. Remember, even though the comorbidities are present, if the comorbid conditions do improve, the insomnia can persist and become chronic. So we need not take the insomnia per se very lightly. The male to female ratio is 1:1.4, that females are more likely to suffer from insomnia. It increases with age. 35% of people who have a family history of insomnia have tendency to get insomnia in their lifetime. 1/3 of adult population suffer from insomnia. Half of the patients who come to general practitioners OPD do complain about a sleep disorder. 1/3 of them report to their physicians and only 5% seek the treatment. Because physicians OPDs or GP practitioners OPDs are so busy and rush, they don't ask for it and the patient even don't complain about it. Vast majorities are persons who are suffering are remaining untreated because of this. 2/3 of the patients are unaware about the treatment option available for insomnia per se, and they go towards over-the-counter medications which are unsafe, not FDA regulated, and they don't know what they are taking. Few of them do take alcohol as a sleep medicine. What does insomnia cause? The impairment and comorbidities with insomnias will increase the risk of present and future psychiatric disorder. One, it diminishes the ability to enjoy a family and social relationship. Increased absenteeism at workplace and job performance start decreasing. Insomnia causes decreased concentration and impairs the memory. One of the important functions of sleep is restoration and memory consolidation. If the sleep is disturbed, the person is not getting sleep, their memory functions also get impaired. Overall quality of life get poor, increased risk of fall, motor vehicle crashes are very common. If you ask someone who meets with an accident, they do say that I had a nap because they were driving late in the night or early in the morning where they didn't get sleep properly. Metabolic syndrome is commonly seen with diabetes, hypertension, and weight gain. There are incidences of increased pain symptoms if the person has insomnia which is persistent, which in turn leads to increased rate of mortality. When we try to assess the case of insomnia, we need to keep these all things in mind. When we ask for the history, we start with sleep schedule, at what time the patient is going to the bed, and at what time actually he is sleeping. If the person says that after an hour or two I am getting sleep, that's not the right thing to do. If you're not getting a sleep within 20 minutes, you should get out of the bed, or else you will not get sleep. Because you will be waiting to get sleep, which again acts at your cognitive center and thoughts will disturb your the sleep pattern. At what time the patient wakes up? This is very important. You wake up at 1 a.m. in the afternoon, 6 a.m. in the morning, or 8 a.m. in the morning. The wake up time is different every day. That means your circadian system is not fixed, which needs to be fixed. That is very important in insomnia part. The circadian system has to be fixed. Whenever in medical history we ask, sleep is an habit which needs to be cultivated in a better way. If the habits are not proper, then a lot of problems do occur. At what time you get out of the bed? If you get up in the morning, you should get out of bed early. Don't try to be on bed for a long time. How is the quality of nocturnal sleep? We need to ask. If there are daytime naps, how frequent they are, how much number of naps, how much time they are getting naps, these all things to be asked. If there are some nocturnal awakening, in the night they are waking up, how many numbers, what are the reasons, are there parasomnias which are there which is causing awakening, we need to ask for it. Any kind of a pre-bedtime behavior, like eating before having a rigorous exercise, or some dysfunctional thoughts that I will not get sleep or something like that, if that is present, so that do contribute to insomnia. Any kind of a compensatory behavior which is done to get sleep, we need to find out that. Any other behaviors like snoring or leg kicking, if it is there in the night, it need to be asked. Medication history is also equally important. If the person has medications which contribute to insomnia, need to be looked at very seriously. Environment of the bedroom is also equally important. It should be serene, calm, black, dark, rather than a lit up bedroom. You need to compare the sleep pattern before this insomnia is seen. That is also equally important, and you need to corroborate the history, because if the person has obsessive compulsive personality, he will not tell that he is getting proper sleep. He will do say that meri neend achhi nahi hai. Even though he is sleeping properly for 7 to 8 hours, he will not experience that he is getting a good sleep. So partner's history, the bed partner or room partner history is also equally important. There is a 3P model which has been used in clinical history taking. There is something called as predisposing factors like genetic and personality traits of an individual, which leads to cognitive and physiological hyperarousal in the individual of insomnia. So these people are genetically and personality-wise prone to develop insomnia. The precipitating factor are the triggers. Right now, what are the triggers which are causing the insomnia to occur, like stressful events, a positive or a negative stressful event? The perpetuating factors are the factors that continues insomnia to persist even though the triggers are gone. The stressful events are subsided, yet the insomnia persists because of this perpetuating factors, like the behavior and thought structures the person has. They say that I spend more time in the bed, or they have a dysfunctional thoughts that I won't get sleep, that kind of a thinking. In the history, psychiatric history need to be asked. Past medical history is also equally important, because there is a bidirectional relationship between the physical or medical history and the insomnia per se. There is no clinically evident physical examination findings of insomnia per se, yet we can find out some amount of comorbid conditions associated with insomnias, like obstructive sleep apneas, where the obese person, like BMI is raised in them, or neck circumference which is increased, or airway examination will help us to understand this. You need to rule out the sleep disorders that mimic insomnias. Sometimes you may not be dealing with insomnia per se. We may be dealing with sleep disorders, like sleep-related breathing disorders like OSA, central sleep apnea, and others. Parasomnias, as Sir discussed now, circadian rhythm disorders, sleep-related movement disorders, and sleep-related epilepsy, laryngospasms, or asystoles. These all disorders may mimic insomnia, but they are not an insomnic disorder per se. We need to rule out medical conditions that may induce the sleep disturbances, like cardiovascular diseases like arrhythmia, congestive heart failure, where the person has nocturnal awakening and they grasp for a breath, MI, varicose veins, CNS conditions like dementia, seizures, strokes, Parkinson's, pulmonary conditions. The GI conditions are very common. Nowadays, because of the lifestyle of ours, where we take late night dinner after 10 or maybe 11, the digestion doesn't occur. We go to the bed. GERD is one thing which does happen. Because of the reflex, the person is not getting sleep. The only thing is take the meals early. Maybe some PPIs will help them. Chronic kidney disease, and in old age, we do see BHP, benign prostatic hypertrophy. They want to go to pass urine for the same reason they are getting insomnia. We give benzodiazepines, how will they sleep? They will be awake because micturition is a normal phenomenon. Treat the BHP, probably insomnia will resolve. So these are all things we need to keep in mind before we address the insomnia per se. Here, the prevalence of insomnia in medical disorders when studied in one of the study, where we can see that the blue lines, all of them, heart diseases, cancer, hypertension, neurological diseases, breathing, urinary problem, diabetes, chronic pain, GI problems, any other medical condition. Without insomnia is always less, with insomnia is high. My thing is over here, what I want to tell you is, ask your patients, does the patient has insomnia? Keep that in mind whenever the patient comes for diabetic follow-up or hypertension follow-ups, because they won't say you. We need to ask them. What are the medications which may contribute to the insomnia? You name anything and everything, it's there in the list. Okay, antidepressants. Now, when the general practitioners do practice, they think that SSRIs are going to give sleep. That's wrong. The SSRIs are going to increase the serotonin levels in the brain, which is, as Deepak addressed, it is wake-promoting hormone, neurotransmitter. So it increases the awakening rather than inducing sleep. So all the SSRIs will not give you sleep. Don't give SSRIs in night, because it may not address the sleep properly. Okay. Apart from agomelatonin, mirtazapine, doxepin, or trazodone, most tricyclic antidepressants, most of the other antidepressants do contribute to insomnia. Cardiovascular drugs like antihypertensives, beta blockers, diuretics, they do cause insomnia. Hormonal medications like thyroid supplements, oral contraceptives, they do contribute to insomnia. Respiratory drugs, like aminophalins, amphetamines, epinephrines, these all contribute to insomnia. Stimulants, anti-Parkinsonian drugs, the anticonvulsants, steroids, nicotine, alcohol, they all contribute to insomnia. Coming to psychiatric disorders and insomnia per se. Here in this slide, I would like you to understand that suicidal risk or insomnia per se considered to be one of the important independent risk factor for suicide. Okay, even though the hopelessness and other anhedonia or depressive symptoms improved, if the insomnia persists, still it is considered to be one of the independent risk factor for suicide. So don't take things lightly. If the patient of depression who has improvement in their symptoms of depression do complain of insomnia, they are likely to attempt suicide if their sleep is not addressed properly. Depression, 80% of patients with depression do complain about insomnia, which is the commonest one. We need to understand that insomnia in depression is always seen prior to the onset of depressive features. That is one thing. And if the insomnia is persistent and comorbid with depression, there are frequent chances of relapses of recurrent depressions in them. Prognosis is not that good without insomnia. So we have a worst outcome in terms of insomnia with depression. This slide explains us the residual symptoms of depression after treating with antidepressants. The mood symptoms, interest, lack of interest, weight, psychomotor retardation, fatigue, guilt, concentration, everything are seen in residual symptoms, but the sleep disturbances is the highest among them. So when we treat the patient of insomnia with SSRIs and antidepressants, the patient do complain about residual sleep disturbance of insomnia, which we need to keep in mind before we go ahead in the treatment and achieve remission in these patients. Manic episodes and sleep disorders. Remember one thing, all decreased sleep is not depression. It may be mania also, because most of the patients of mania, they don't feel like sleeping. They feel they are active, alert. They will have sleepless days together for weeks. Okay. So the reason is different. They are more active. Then anxiety disorders and depression, anxiety disorder and sleep, both are seen together. The insomnia and anxiety symptoms occur together, and they most commonly cause abrupt awakening in the night. Nightmares are commonly seen in PTSD patients, and nocturnal awakening and hyperarousal states. Flashbacks are also seen in them. Schizophrenia, they do have initiation and maintenance difficulties. Here, the sleep is very poorly restorative, and hence cognitive impairment on a long run in schizophrenic patients are seen. This slide in the end, what I'm telling over here are insomnia in psychiatric disorders. The last one is very important. 59% of patients with insomnia do not have psychiatric disorder. So don't have that notion in mind that sleep disorder mein insomnia dikh raha hai to some psychiatric condition has to be there. No, it's not the truth. Few patients who present with insomnia, few, not more than few, you can say, around 60%. They don't have any primary psychiatric disorder, which we need to keep in mind to address this issue. What are the tools available for assessing insomnia? One tool is sleep diary. We ask the patient to maintain this diary for 2 consecutive weeks, where he needs to note down the time, at what time he goes to the bed, at what time the lights are off, at what time he is getting sleep. If there are any nocturnal awakening, if they are, then how much time he is awake and going back to sleep again. Awakening in the morning, at what time. Every day he is waking up in the same time or different times need to be kept into mind. If there are naps in the afternoons, how frequently the naps are there and how much duration of them are. This is one of the useful way to diagnose insomnia in a different pattern wise, initiation, maintenance, and terminal insomnia per se. This is how it looks when we give to the patient. The second tool is actigraph. Actigraphy is a device which is worn on the wrist that records the movements and employs an algorithm to estimate the sleep and wake periods. It is satisfactorily reliable, but not required in evaluation of insomnia per se. It's not routinely done. This is how the device looks. Polysomnography. Polysomnography is gold standard to distinguish sleep from wake, but not routinely advisable in the diagnosis of insomnia per se. Where we use it to rule out possible explanation for poor sleep, such as sleep apnea or periodic limb movement disorders. This is how it looks. A lot of questionnaires are there. I don't want to go into details because of the time frame which I had got. Ipswich Sleep Scale, Insomnia Severity Index, Dysfunctional Belief and Attitudes about the sleep, Pittsburgh Sleep Quality Index. This is ISI scale, which template I have put. All the scales will let us know how significant the insomnia is. Subthreshold, threshold, significant, clinically moderate or mild. Those are all things we can understand with these scales. Formulating a treatment plan. Coming back to our case, this lady gives us a history that when asked, she has a stressful job of marketing, but she adds that it is no different than usual. She is doing since beginning. She is in a stable relationship with her partner. She has no children, but has 2 dogs. She doesn't take alcohol since 6 years, but has a binge drinking pattern in the college. We need to keep this in mind. Binge drinking pattern, always we think about mood disorders and bipolar or depression or something like that. She is not on any medications currently. Her BMI is on a higher side, that is almost 29. She has a snoring issue. So OSA need to be kept in mind when we see this patient. When we are formulating a treatment plan for insomnia, we need to individualize and tailor make it. So every patient, we cannot start with the same drug and same therapy. It should be tailor made. One person cloth will not fit the other person. So that's very important in the treatment of insomnia. When we discuss about short-term management, pharmacotherapy is indicated. In chronic insomnia, CBTI, that is cognitive behavioral therapy for insomnia, is preferred. Goal of the therapy is to increase the latency of the sleep, improve the sleep latency, total sleep time, reduce the awakening, quality should be improved. Daytime symptoms like the tiredness and fatigue, these all things should be ameliorated. We need to sustain the treatment even after stopping the therapy or the drug. That should be our goal. The algorithm explains us how we approach the case. Whenever the case comes, we ask the history, what has been explained earlier. Is it affecting the quality and the functioning of the individual? If no, probably he is a short sleeper and a supportive therapy and reassurance is enough. If yes, then look for the comorbidities. A medical or a psychiatric comorbidity, if it is present with insomnia, treat the comorbidity first. If the symptoms of insomnia relieves, that's it. If it persists, then we need to go for other like forms of treatment, like medications or CBTI. If no comorbidities are seen and insomnia is seen as an isolated entity, medications to be used for a short term, or you need to think about behavioral therapy for a long term. Depending on the pattern, we divide the insomnia in 3 stages: initial insomnia, mild, middle insomnia, and terminal insomnia. Initial insomnia, usually the patient has difficulty in falling asleep. Most commonly, anxiety disorders do present with initial insomnia. Shift workers, restless leg syndromes do have this. Middle insomnia, sleep apnea usually presents with that. Depression symptoms, patients do present. Terminal insomnia, early morning awakening. They have difficulties in getting up on a right time. Earlier, they used to get up at 6 o'clock. Now they are getting up at 4 o'clock and not getting sleep at all. So that is terminal insomnia. Depression and advanced sleep phase disorder, patients do complain about it. What are the options available for insomnia? Whenever you talk about choosing of a molecule, we need to look at the age of the individual. Older individual, we need to see the risk of the falls and excessive sedation in them. Comorbid conditions need to be looked at. Pharmacokinetic properties of the drug need to be looked at. Drug interactions and adverse effect need to be considered. The comorbid conditions, whatever they are present, we need to treat them. Like obstructive sleep apnea, we need to go ahead with the CPAP, BiPAP, or some devices. RLS, the treatment has been discussed in detail by Sir. MDD, antidepressants need to be considered with a sedating property. GERD, shift worker, bedtime melatonin, or early morning, sometimes modafinil can be helpful to achieve a good circadian rhythm in them. These are some of the FDA approved drugs. Benzodiazepines are the main drugs, and the Z drugs, that is zolpidem and esapicolone. Melatonin receptor agonists like remeltion, doxepin, and dual orexin receptor antagonist like suvorexant. These are the new drugs which have come up, which are considered to be helpful in treatment of insomnia. Coming to the benzodiazepines per se, short-acting benzodiazepines are preferred for initial insomnia, long-acting for terminal insomnia. They do act at GABA A receptors, and because of their action in terms of anxiolytic and myorelaxant effect, it is helpful if the patient also has anxiety, and pain symptoms associated with insomnia. The problem in benzodiazepines is tolerance and dependence. When you start with 0.5 mg of clonazepam, we never understand when he takes 4 to 5 tablets in the night within a period of a year or two. So we need to be careful and explain the patient about the tolerance and dependence of these benzodiazepines. Adverse effects are same, daytime sedation, and those all things. The abuse potential is very high. Whenever you start benzodiazepines to these patients, the insomnia, we need to think before you start if the patient has some history of substance abuse. Let it be alcohol or nicotine or anything. Z drugs are the second group of drugs. They are zolpidem and these things. They do act at GABA A receptor, but only alpha 1 receptors. It is helpful in onset and maintenance of sleep difficulties. They are not having any kind of effect of anxiolytic or myorelaxant property. It does have dependence and abuse potential. On the extreme end, if you see the side effects of this drug, memory impairment. Whenever you prescribe benzodiazepines, sometimes the patients may say that I do have memory lapses. Anterograde amnesia is quite commonly seen. So that is very important. We need to keep that in mind. Even with zolpidem, as sir explained, hallucinations are common. Occupational hallucinations, kuch kar raha hu, bol ke karte rehta hai. So keep that in mind whenever we prescribe zolpidem to these patients. Toxepin is a very old drug. Before I started my psychiatry career, it is the oldest drug. When I started reading it, this drug is not that frequently available in the market right now, but it is extensively studied in treatment of insomnia in a lower dose. 3 to 10 mg dose is considered to be useful in treatment of insomnia in terms of maintenance, this middle and terminal insomnia patients. The quality of sleep is quite well improved because of H1 antagonistic property, antihistaminic property. Antidepressant dose is quite higher, 75 to 150, but not that much helpful as an antidepressant currently because of the side effect profile of this drug. A lower dose, it is very good, and it is the drug to be considered if there is a history of abuse in the patients. Substance abuse patients, this drug is very frequently used. It doesn't have potential for dependence. It can be considered in the patients where insomnia is associated with allergic symptoms, as it has an antihistaminic property. Melatonin and its agonist, it is a hormone secreted by the pineal gland, and this is going to help in terms of sleep onset. It helps in sleep onset. Middle and to some extent not. The recent literature related to the who have decreased sleep, this drug has shown to have good benefit to help in terms of maintaining the circadian system in them. It is also without any abuse potential. Remeltion and agomelatonin are the two melatonin receptor agonists available. Remeltion is short acting, which is almost 3 to 4 hours, helps in falling asleep. Agomelatonin has an additional action on 5-HT2C receptor antagonism, which is helpful in improvement of the mood. So antidepressant action is there with this drug. Melatonin, as it is an hormone, we need to use cautiously in reproductive age group patients, especially in females. Infertility issues have been reported in few cases. Orexin receptor antagonist. Suvorexant is one drug which has come up. In India, we don't use it frequently. I don't think so. We have any first-hand experience over here. This drug in US and other Western countries is doing really great. Maybe it's a time for us to come up with this in near future. It helps in onset and maintenance. And there is no significant rebound insomnia on discontinuation, which is significantly reported in this drug. Some amount of abuse potential is seen as compared to zolpidem in these patients. It is helpful in onset and maintenance of sleep in these patients. Over-the-counter drugs. This is one thing which is commonly used. Diphenhydramine. Diphenhydramine, it is an antihistaminic. Doxylamine is also an antihistaminic, but it has an anticholinergic side effect. Always be careful when we use this drug. One of the case where the patient started diphenhydramine and or doxylamine, old patient, he came up with a history of confusion, delirious kind of picture with urinary retention, dryness of mouth, and the resident called and told that late onset psychosis ka picture lag raha hai sir. It is drug induced psychosis or delirium rather than late onset psychosis. It's a drug induced. So he was been prescribed antihistaminic with anticholinergic side effect also. Off-label drugs which are used for insomnia are extensive, antidepressant, antipsychotics, and those all things. But the efficacy, safety, prescribing guidelines are not clearly understood with them. Antidepressants, trazodone, as earlier discussed, it is going to help in terms of insomnia. Tricyclic antidepressants, mirtazapine, agomelatonin, they do cause good benefit. They do give good benefit in induction of sleep. Antipsychotics, quetiapine is one of the favorite when we see about antipsychotics, especially in terms of insomnia. But we need to be careful whenever we prescribe quetiapine because of hypotension potential and a lot of falls and sedation. These all things are common side effects with quetiapine. Olanzapine and chlorpromazine can also be prescribed. Gabapentin and pregabalin are anticonvulsants which has insomnia sleep promoting property. This helps in patients with pain or partial seizures or even with restless leg syndrome. So we can use this drug for these patients who has insomnias. We need to be careful while we use this drug in patients with renal impairment. Dietary supplements, they are not regulated by FDAs. Today is our sponsorer, Sleep Night, is also a valerian extract and dietary supplement preparation. One tablet at night shown to have good benefit in inducing good sleep. To cut short, what pharmacological options we have? For initiation, we can give Zepiclone, Zolpidem, or Ramelteon. For maintenance, doxepin. Respiratory compromised patient, Ramelteon or Suvorexant can be used. If there is abuse potential, then better to go with doxepin. Try to understand, is there any prior failure with the treatment, and try other treatment options available. Patient preference need to be considered. Coming to the cognitive behavioral part, I will take another 2 minutes. I think it's a very lengthy session because this is also very important. So in CBTI, that is cognitive behavioral therapy for insomnia, it is multimodal approach and it is found to be benefiting in a long-term case. Remember one thing, if you want a quick response, the option is only pharmacotherapy. Don't think that CBTI will help. At least 4 to 6 sessions are required to show some benefit. It will not happen overnight. It is an art, it's not the science right now. So what is the sleep hygiene? OOB, that is out of bed. You need to know that the get out of bed time should be same, even though it's on the weekends. 7 बजे उठना है तो 7 बजे उठना है. चाहे तो आप सो जाओ 1 बजे रात को, 6 बजे सवेरे सवेरे, but 7 बजे उठो. Get out of bed is very important. If you alter that time, your sleep cycle completely become disturbed. So get out of bed is very important. Same time in the morning need to be maintained. Increased light exposure in the daytime is equally important. Exactly opposite is important in the night. Don't expose yourself to the light in the night. Daily routine activity, exercise regularly, step aside your worries. Sleeping room comfort is very important. Keep it dark. Do something relaxing prior to the bedtime. Doing some relaxation techniques, deep breathing exercises will also help. A lukewarm bath an hour prior will help. Avoid alcohol. As Sir told, it plays with the sleep architecture. Everything will disturb because of alcohol. It will not give you good quality sleep. You may get a quantity of sleep, but quality is very poor. So that's not going to help. Caffeine, nicotine, other substances need not to be taken in the night. Exposure to the light should be less, especially the smartphones. That is very important. Some blue lights do come up from the TV and the smartphones, which keeps you awake. That melatonin, pineal gland, suprachiasmatic nucleus circuit is completely fired. So we need to be careful. You stop watching TV, stop watching the smartphone. वो स्मार्टफोन पे नाइट फिल्टर आता है, वो भी हेल्प नहीं करेगा. Okay, don't do that also. Okay, there are some night filter glasses available which you can use it if you want to see something on TV or something else, you want to do it on computers. No heavy exercises or heavy meals 3 hours prior to bedtime. Use bed for only sleep. Napping in the daytime should be very less. If not, don't do it at all. Don't watch the clock. अभी नहीं आया, आधा घंटा हो गया, अभी नींद नहीं करा, 1 घंटा हो गया, अभी नींद नहीं करा. Don't do that. You will not get sleep. Negative conditioning will happen to the brain. Don't try to sleep in the bed. If you get sleep, then go to the bed. Bed पे लेट के सोने की कोशिश नहीं करना है. That will not happen. Okay? If you are in the bed, within 20 minutes, you should get sleep. If not, get out of the bed. Do something boring. If you get sleep, come back to bed. That's very important. No noise, excessive heat and cold in the room should be avoided. Behavioral components of the therapy are stimulus control. There is conditioning which has happened in few patients. When they go to the bedroom or see the bed, they don't get sleep. They become psychologically or physiologically aroused, fearful, anxious, frustrated. Bed serves as a learned cue or conditional stimuli for arousal. वो देखते ही उनकी नींद उड़ जाती है. Oh my God, how can I get sleep? So that kind of a fear comes up. Okay. So the first thing what we tell is move away from the bed if you are not getting sleep and avoid any other activity in the bed apart from sleeping, like reading book, watching TV, eating food, whatever it is, not on bed. Okay. Maintain a wake-up time, which is very important, as I told you. Next is sleep restriction, one form of a therapy, which is very important. There is something called a sleep efficacy, which means that the time spent in the bed and actually time slept should be almost equal. आप 9 घंटा बेड पे हो, 5 घंटा सो रहे हो, ये मत करो. 9 घंटा बेड पे हो तो 8 से 8.5 घंटा आपको सोना है. That should be our goal. It should be more than 85% sleep efficacy. Okay, so that should be the target whenever we go ahead with sleep restriction therapy. Relaxation therapy, n number of things are there: progressive muscular relaxation, biofeedback, abdominal breathing, then imagery training, meditation seeking, attention focus procedures can be done. One more thing which is quite reverse of usually done is paradoxical intention therapy, where some people have a performance anxiety kind of a thing. Okay, अभी कहीं स्पीच देना है तो उसको डर लगता है, मैं कर पाऊंगा नहीं कर पाऊंगा, 4 लोगों के सामने बात करने को डर लगता है. The same way these people have the fear of sleeping. So I'm not going to get sleep. That's what the performance anxiety tells them. So what we do is, in this therapy, we ask them to do them opposite of it. Stay awake in the bed. rather than going to sleep. So when they try to stay away in bed, one fine time they will get sleep. Okay, so this is paradoxical intention therapy. The cognitive components are also equally important, where sleep-related worries need to be looked at. Unrealistic expectations about the sleep if the person has, we need to be very careful about it. They do say that मुझे 8 घंटा सोना है, मैं 7.5 घंटा सो गया. It is not proper. Their expectations are very difficult to understand. So we need to understand that the expectations should be looked into it properly. Catastrophic thinking. So few people examine that one bad night of sleep there is going to harm complete their sleep pattern and cause a lot of health issues. That is catastrophic thinking. We need to tell them that previously in your lifetime you had a bad night's sleep, but you performed well next day. जाके काम करे, परफॉर्मेंस कहीं पे था तो दिए, आप पेशेंट भी देखे, हर चीज करें, 4 घंटा सो के करें आप. That doesn't make that you have a difficulty with sleeping. So one bad experience will not catastrophize your thought process. So these all things should be corrected. There is something called as constructive worry exercises, where we ask the patient to list on 3 problems which keep them lightly awake in the night, and we ask them to write a solution related to it. And whenever they are awake, we ask them to tell them that ये मैंने सोच रखा है, now I am going to sleep. So that will help them in some way. This is the last slide. So when we need to stop the treatment, if we are going medications, drug holidays are must. Don't make them dependent on the molecule. That is very important. CBTI, when we need to stop, 4 weeks of stabilized sleep before we consider stopping it. That is the dictum. Other therapies like music therapy, homeopathy, acupressure, aromatherapy, whatever works for you, we can try on the patients. Thank you for the patients listening. I ask the chairpersons to take over.
Alok, I compliment you for your exhaustive and informative talk on the sleep insomnia, which is more important for especially in general practice, day-to-day practice. And one thing I observed in my general practice, in my psychiatry practice, is misuse of the mobiles by the younger generation and overnight watching of the TV in the adult population. You have any comments on this? Because that is one of the reasons for the induced insomnia. That's what I thought.
Yes, sir. Very rightly said, sir. Nowadays, what is happening is the technology is controlling us rather than we controlling the technology. It's going towards that we are going to see it or we want to off it. It's not happening. We are getting more impulsive and compulsive towards the use about it. The addiction and use of these gadgets, it's a very difficult task to go about. And I think we need to limit the time. We ask the person to limit the screen time to at least an hour or 2 each time when they see. And prior to sleep, at least 2 or 3 hours prior to sleep, do not expose for a screen time for at least 5 to 10 minutes. You can see mobile for a minute or 2 or maybe 15 minutes if there is something which is important, but not more than 10 to 15 minutes. If you are seeing a TV or something like that, you should complete it. If you are planning a sleep at 12 a.m. in the night, we should stop watching before 9. 9 के बाद नहीं देखना. We need to plan our sleep schedule properly, sir. As I told you, it's a habit. We need to cultivate it. Difficult to do it. The quality of sleep will be poor in most of us, as NM partners are told, but we need to strive for it. We need to cut short the use. Screen time need to be reduced aggressively, and if required, some therapies and some form of medications can be used if the addiction or disorders have been seen.
So what I advise the clients, my clients, is that once you have dinner, you should not go for any electronic activity. I don't say you have to work for 15 minutes or like that. I ask them to stop after dinner.
True, sir. True. That's also, if that is working for the client, that's the best thing to do.
Any questions?
Yeah, one more session is there, panel discussion. Dreams. we thought of including dreams. Yeah.
I think 8 years ago, I have purchased 2 books. One very old, Significance of Dreams, by Sigmund Freud.
Interpretation of dream.
Interpretation of dreams. And one more from 10,000 interpretations of dreams by Master's Inman Miller. Recently, I have from email I got it. It's a wonderful one to go with. And another a Muslim writer, Abu Amin Saab or something. He has significance of dreams in Quran and Surah. It's a wonderful book as well as the scientific approach to it. And the vintage of that is HOD Psychiatry. It's a wonderful book. I don't know the new generation of psychiatrists least bothered about the dreams. They won't read the dreams and they don't believe the dreams, but it's the significance is still there. In depression, there are several types of the dreams. And also, patients, when you ask direct questions about dreams, they will get relieved and believe in you. Oh, this doctor knows this. It is a wonderful thing. And your practice also will increase. Thank you.
We thought of including dreams, but because of the time constraint, we didn't able to fit this interpretation of dreams or neuroscience of dreams. Next time when we discuss, we would like to involve this into our discussion. Thank you.